Uh, Good morning, everyone. I'm Dr. Raghav Malik, and today we are discussing a very important topic. Our instruction course is on disc at risk, that is a crossover between glaucoma, myopia, and refractive surgery. What things we have to consider about the optic disc and the retinal nerve fiber layer and the intraocular pressure, the corneal thickness, and multiple factors which come into play when we are thinking of doing refractive surgery in a patient who is myopic, and of course the crossover between myopia and glaucoma. With me, I have Dr. Tulika Chauhan, who is our mentor, and she is, I would say, a very approachable mentor for all of us. She's a cornea consultant and cataract refractive surgery, a consultant in cornea, cataract, and refractive surgery at Center for Sight. And welcome, ma'am. Thank you for joining us. And we have Dr. Kanika, who is a fellow, now a consultant with us in the same cataract and refractive surgery. So please, can I have Dr. Isha with your talk? Thanks.
The interaction of myopia with glaucoma risk remains complex, largely because of the retinal and nerve fiber layer damage that occurs in myopia alone. So, whether to treat for glaucoma relies on the suspicion level of the clinician, who must consider other risk factors for vision loss. Ultimately, it is the progression of glaucoma like findings that determines whether or not it is to be treated. So, let us look at a case scenario. This was a 24-year-old female referred for refractive surgery. So the findings, best corrected visual acuity with a refraction of -5 diopter sphere in the right and a -1 cylinder, and -5.5 spherical in the left with a -0.75 cylinder, was 6/6. CCT okay relatively for 534 and 549. This is the topography of the right eye. So the readings are K1 is 42 and K2 is 45, and the map looks okay. No local areas of steepening, thinning. This is the left eye. K1, K2 relatively on the higher side, 47 and 50, but then regular structure. So looking at her optic discs, now we can see here that the ONH is slightly nasally inserted. So the ONH is slightly nasally inserted here, and the CDR looks suspicious. It's a CDR of about 0.6 in both the eyes. There is bilateral beta zone parapapillary atrophy without any visible defect of the RNFL. It's better to have a red-free picture in order to see defects of the RNFL. And there is no significant focal rim notching or saucerization. So this patient was referred for a glaucoma opinion. And also she had a similar looking disc in her mother, who had come for a routine checkup. So the fields look okay, perfectly all right. This is the RNFL imaging of which shows certain red areas in the right eye superior and nasal quadrants, and in the nasal quadrant of the left eye. But then the RNFL symmetry is well maintained. So what are the dilemmas in this case who has come to us for a refractive surgery? This is a young myopic patient with large optic discs which are glaucomatous looking. So does this myopic patient have glaucoma? And her OCT imaging shows bilateral signs of structural anomaly of the optic nerve head, or the red disease which we saw. So should we proceed for a refractive surgery? A little bit of background. So glaucoma is a leading cause of irreversible blindness worldwide, with 67 million affected, 10% of whom are blind. Incidence of glaucoma is increased in patients with more than 6 diopters of myopia. As we know, myopia is increasing rapidly worldwide, with the myopic population expected to double in around 2050. High myopia is defined as the axial length more than 26.5, spherical equivalent more than 6 diopters. We already know that. So use of refractive laser correction for myopia further complicates this picture. Why? Because there is a transient rise in IOP during LASIK surgery, which may put an at-risk patient in further damage of due to glaucoma or even retinal vein occlusion. Then IOP measurements are inaccurate after laser refractive surgeries. Why? Because of alterations in the CCT and corneal curvature. And patients with glaucoma are at a higher risk of developing steroid-induced IOP elevation because of the post-operative regimens. These are some large studies, large center studies, which have established that yes, myopia is a risk factor for glaucoma. So why are myopic eyes predisposed to glaucoma? As you can see, lamina cribrosa is the primary site of RGC injury in glaucoma because it's a connective tissue sheath, a narrow sheath through which the axons pass. So very prone to damage from compression. So shearing forces in the lamina cribrosa secondary to connective tissue changes are greater in eyes with a longer axial length than those with a shorter axial length. I've quoted the study below. So this may explain the higher susceptibility of myopic eyes to glaucomatous optic neuropathy at any IOP. Posterior deformation of the Brooks membrane is observed in myopic eyes, and that is associated with functional glaucomatous damage. And confocal imaging has shown that the height of the optic disc is relatively decreased with increase in the axial length. But sometimes imaging a distorted optic nerve head that is structurally different from that of a structurally different from that in a non-highly myopic population, which actually is used as a reference normative database in the OCT imaging software, may lead to misdiagnosis. Why? Myopic eyes can be associated with optic nerve head abnormalities that can create diagnostic challenges. Quantitative parameters on RNFL imaging are important, but false positive findings of RNFL thinning are seen in non-glaucomatous but myopic eyes. Interpretation of RNFL measurements is further complicated by changes like myopic optic disc tilt. So who do we call a disc suspect? Optic nerve head or RNFL appearance suggestive of glaucomatous damage. Highly myopic nerves can exhibit nasal insertion of the optic nerve, which we saw in this case, tilted disc, shallow cup, peripapillary findings like scleral crescent and PPA. Then we know about the posterior segment anomalies that are seen in highly myopic eyes. Let us look at some confusing situations. Now here, in both the eyes, there is a nasally inserted optic nerve with a scleral crescent and peripapillary atrophy. Not much cupping, but the cups look shallow. Then these are two different patients, image of the right eye. So on the left picture, the disc is nasally inserted with healthy NRR, relatively healthy NRR. On the right, it's a nasally inserted disc with a larger cup. Now, this appearance is a diagnostic quandary. But when compared, cupping is obviously more in the right picture than the left picture. Then here we can see a myopic scleral crescent, 360 degrees, hardly any discernible cup to disc ratio. Nerve fiber layer imaging in myopia, there have been studies which show that there is a average decrease in RNFL with increasing refractive error and increasing axial length. Another case, just an example, then this case was labeled as glaucoma, referred for a second opinion, and she had a history of using prostaglandin analogs. The red-free picture shows a perfectly normal-looking nerve in the right eye and nasally inserted nerve in the left eye with a temporal crescent. Global thickness shows superotemporal RNFL thinning, but it is doubtful whether the OCT scan actually considers the border of the PPA or the actual disc margin as the temporal limit of the scan. The red-free image shows definite cupping here, so this is suspicious, and the RNFL shows a red disease. Another paper. Now here, they are developing a myopic normative database. So this has application in improving the specificity without compromising the sensitivity for detection of RNFL abnormalities in eyes with high myopia. So such a myopic database would be very useful in such patients. Most important, we need serial disc photos to monitor glaucoma. These are better than RNFL imaging because there is less noise and it is not impacted by peripapillary atrophy, scleral crescent, disc tilt and all these things. And it can better monitor for change like increased cupping localized rim notching, increased PPA, and vascular changes. Just a couple of slides on the visual fields in glaucoma. High myopia can cause visual field changes due to nerve or retinal abnormalities. Visual field defects that favor myopia are temporal defects respecting the midline and an enlarged blind spot due to PPA or scleral crescent. Those that favor glaucoma are nasal step, arcuate scotoma, and paracentral scotoma. So these three are different examples of myopic eyes without glaucoma with visual field abnormalities. So my take-home points are that our patient, the case that we discussed, was a disc suspect with a normal CCT pressures and visual fields. Red disease shown in OCT RNFL is explained by lack of a normative myopic database. Although myopia with suspicious looking optic discs is a risk factor for the development of glaucoma, it does not preclude refractive surgery. All such cases need a thorough glaucoma workup, and serial disc photographs would be much more useful compared to RNFL imaging. So, thank you.
Thank you, Dr. Isha. So I just want a quick question. So would you want all such disc suspects or patients who have a disc asymmetry or large cups, should they all undergo glaucoma workup, or we can avoid in some cases? What case would you advise that we should send a patient for a glaucoma workup? What should be the red flags?
Okay, so for like this in this patient, there was a strong family history.
Yeah.
So that is there. Then the red disease seen on OCT on RNFL imaging. So yes, glaucoma workup is a mandatory thing for everyone undergoing refractive surgery as a part of the preoperative workup.
Okay.
I would.
Thank you.
So Dr. Isha, another question. So in your regular practice, do you prefer all the patients should undergo, like as you said, it's a mandatory practice. Do you practice that in your regular practice?
I try to, ma'am.
Okay.
Can we now have Dr. Tulika? I would say 90% of the patients who come to our center go through ma'am, or if they go to someone else, of course, ma'am's opinion is always important. And she will be talking about PRK, LASIK and SMILE. Are you under pressure? Thank you, ma'am.
Thank you, Dr. Raghav. Sorry. A very good morning, everyone. So as Dr. Raghav already explained that we are here to decode the enigma of the close relationship between myopia, glaucoma and refractive surgery. So my topic is...
I will be speaking on the high on low IOP measurements and steroid response. So the first question is, what is steroid response? It was first reported in 1950 after the use of dexamethasone and systemic steroids. The definition stands that ocular hypertension considered over 10 millimeters of mercury from baseline after the use of steroids. What is the prevalence? The prevalence of increased IOP after surface ablation has been reported in literature from 11% to 25% of the cases. Dexamethasone is a strong steroid, therefore maximum chances up to 25%. Fluorometholone, a mild surface steroid, 1.5 to 3% only. Steroid response and refractive surgery. Is there a link? Most definitely yes. It can occur as a result of normal post-op regimen where we use steroids or following treatments for diffuse lamellar keratitis. In one series, almost 2.8% of eyes experienced an IOP elevation and converted into glaucoma post-refractive surgeries. When do you suspect a steroid response? Timeline is 3 to 6 weeks post starting steroids after refractive surgery, and usually it normalizes within 2 weeks after the cessation of therapy. What are the signs and symptoms? Firstly, worsening of visual acuity and loss of visual field. Second, increased measured intraocular pressure. Worsening symptoms with corticosteroids. Interface fluid seen on slit lamp biomicroscopy. Cystic corneal edema which extends beyond the flap margin. Thickened flap. Corneal steepening on corneal topography, which is most likely due to the interface fluid pushing the central cornea anteriorly, sometimes associated with late onset DLK occurring after 10 days following surgery and occurs approximately 2 weeks after administration of steroids. Now, what is the dilemma? The dilemma is that normal corneas, thinner than normal corneas give low IOP readings, whereas thicker cornea give false high readings. Applanation tonometry is designed for 520 microns, which gives the correct values. But post-refractive surgery, if the central corneal thickness is around 450, it already underestimates intraocular pressure by 5.2 millimeters of mercury. So after excimer laser surgery, the mean drop is 0.63 millimeters of mercury per diopter of correction, which is greater in LASIK as seen with surface ablation. Surface ablation patients with the preoperative refractive error of less than 5 diopter may have negligible decrease in IOP measurements. This is a table of summary where all these studies use different ways to measure IOP, and in this review we found that the minimum deviation from the correct values was seen in DCT, whereas Goldmann applanation tonometry shows a high variation, NCT shows a high variation, DCT was the one that showed least variation from the correct values. What is dynamic contour tonometry? DCT uses a piezoelectric sensor to dynamically detect changes in the intraocular pressure. It is least affected by refractive surgery, and hence it is the recommended technique. There are other formulae. These were given by Yang et al. Last year in a published paper. The IOP corrected with Pentacam. So for SMILE, they suggested the Shah IOP formula. For femtosecond laser, LASIK, they use the Dresden IOP, Kolar's IOP, and or Sengupei IOP for the femto-LASIK, femtosecond contura LASIK. They also use the Corvus ST, and they gave they gave the formula that biomechanically corrected intraocular pressure is more accurate as compared to the NCT IOP. So another thing, we have to look out for the myopia, because most of the patients that come to us in the clinic are young high myopes, and high myopia is a documented risk factor for steroid response. Myopic laser vision correction artificially lowers IOP measurements post-operatively because of the thin cornea, which can lead to optic nerve cupping visual loss if not detected on time. How do you manage steroid response? Firstly, measurements of central cornea to be taken. Cornea peripheral measurements, preferably temporal measurements to be taken, temporal more than nasal, using tonopen, pneumatotonometry or applanation tonometry. Simple discontinuation of steroids leads to the stoppage of symptoms within 2 weeks. If there is no relief, then we do medical management using acetazolamide or topical timolol. So what do we conclude? Number one, early diagnosis of steroid response. Close periodic monitoring, especially in patients with family history of glaucoma. Thank you.
So Dr. Garvita, I have a question for you.
Yes, ma'am.
So suppose if you're saying that you should stop the steroid if there's a steroid response.
Yes, ma'am.
And then patient underwent a surface ablation where the apical remolding and stromal changes will happen because of the anti-inflammatory.
Yes.
So what do you prefer to give to the patient if you have to suddenly stop the steroid?
Ma'am, first we should move the patient to mild steroids. For example, we're giving prednisolone. So we have to switch it to milder steroids like fluorometholone or prednisolone, loteprednol. And then we should taper quickly the steroids, and then we should stop it.
Because definitely after surgery, the collagen remolding and the apical remolding will definitely happen, okay?
Yes, ma'am.
So we cannot suddenly stop. That's why I wanted to ask the audience that we should start something which has an effect on surface, right?
Yes, ma'am.
Okay. Thank you very much.
Thank you, ma'am.
Our next speaker is Dr. Raghav Malik. He's a cataract and refractive surgeon with Center for Sight, and he's dealing with refractive surgeries on large volume. So he's going to cover IOP rising keratofractive surgery and the phakic IOL for us. Thank you.
Thank you, ma'am. So today I'll be speaking about, so there are two types of refractive surgeries in general. One is a cornea based, that is a laser vision correction, and the other is a phakic IOL. So both sets of surgeries do have their own complications, their rises in IOP, and there are certain factors which we have to consider keeping in mind whenever the pressure rises in a post LVC and a post ICL. So the morbidity of glaucoma, as spoken by my co-instructors till now, among myopes is much higher than the normal general population. So we always have to keep that in mind. So if you look at laser vision correction and raised IOP, so most, I would not say most, but yes, many of our myopic patients are at greater risk of steroid response. There are many factors which are not known till now, but yes, if we do have a myopic patient who is given a steroid, the chances that he or she will develop a steroid response are much higher than normal population. So we have to keep that in mind, and couple that with a thinner pachymetry after a corneal surgery, we will have a higher pressure because of steroid response and an under-read IOP reading. So we have to consider both of these options. Now, steroid-induced glaucoma, steroids are commonly given after LASIK or any corneal procedures just to decrease the corneal haze and avoid a myopic regression. Manifestation of steroid-induced glaucoma is similar to POAG, and myopia is always vulnerable to elevated IOP. PISC has been described by Dr. Tulika, so I won't go in detail. But yes, topical steroids are not only ineffective but also may aggravate the corneal haze, so we have to consider before giving steroids in cases of PISC. Goldmann apnea tonometry is a gold standard for IOP measurement, but yes, the jury is out whether you want to use the Goldmann immediately after a LASIK, because we have a flap that is still in the weak stage. So we have to consider whether we should give in a Goldmann or not, or should we consider a DCT or just an NCT. So thinner than 520 micron cornea leads to an underestimated IOP readings, and lesser pressure is required to flatten the cornea. So we will have under-read readings. This is of course the chart that we use for IOP correction in a normal cornea if that has not undergone refractive surgery. How much we add the pressure or decrease the pressure given this is basis the average Indian cornea. So if we have a 540 micron cornea and a -8 diopter refraction, and we make a 110 micron flap, approximately 100 micron ablation, that is about 220 micron reduced. So the post-op cornea is 440, and the IOP that we get after the surgery is 18. Is everything okay? So we see that there is almost a +7 correction, that this 18 could actually be 25. Of course, these readings are very dynamic. 18 is not always 25, but yes, even if it is 23 or 24, that person could be having continuous loss in RNFL. So we have to consider this. So corneal flap interface fluid after a LASIK also caused a lower IOP leading. So immediately in the post-op period, there is some haze or there is some fluid inside the stromal pocket in a relax or inside the flap of a LASIK, which can give us an elevated IOP. So this has also been reported a potential lifelong complication after LASIK, that is interstitial fluid syndrome, potential space between the flap and of course the pocket and smile. Clinicians might increase steroids to decrease this, but this will further increase the pressure. So it's a continuous cascade that begins, and we may end up causing much more harm to the patient. So treatment of raised IOP after an LVC, there is no particular protocol. There's combination of anti-glaucoma medications we use. We as a practice surgeon should not treat the patient ourselves. We should always include a glaucoma surgeon or glaucoma physician in our treatment of a post-op raised IOP in an LVC patient. But generally we switch to low potency steroids, or we decrease the frequency, and also complete stoppage of steroids, but the patient has to be kept under observation very frequently. Now post ICL, yes, there is a rate of occurrence of raised IOP, and it has been reported from as low as 0.8% to as high as 26%. There are many surgeons who do their ICLs under hydration without viscoelastics. They say yes, that the pressure rise is much less, because a bolus of viscoelastic under the ICL is something that can cause some increased volt in the initial phase and can give us a rise in IOP. So I'll just quickly show a video of an ICL being implanted under the ASOCT. Yeah. So I'm not showing the loading and the surgery. What I just want to highlight is that once the ICL is loaded inside the injection inside the eye, you can see immediately, you will see a very good volt. So you see in this towards your right, let me just focus on the OCT. Yes, so just look at this image. So this is our wall of the lens, and this is the wall that we have between the ICL and the between the ICL and the cornea. So this vault, immediately you can see if it is very high, we can have an angle, we can preclude the patient to an angle closure. So prevention is always better than cure. Systemic and ocular history is very important. Refractive status, slit lamp biomicroscopy, endothelial cell counts, biometry, keratometry, pachymetry is very, very important. Intraocular pressure and gonioscopy before a phakic IOL, just to see whether the angles are open or not and is there any pigment dispersion or not. So factors that predispose an eye to high IOPs, position of the ICL. Like I said, we should do a very good ASOCT to see the vault. The vault should be measured. This I learned from Dr. Tolika, that even on the first day, you should measure the vault. If your vaulting is high or it is increasing progressively, we should take into consideration that and manage the patient accordingly. Pupillary block, yes, the anterior lens vaulting designed to prevent crystalline lens contact predisposes the eye to pupillary block glaucoma, and then a prophylactic PI is recommended. The new models of ICL that we have, that is the version 4C, that has a centra flow which is 3.6 millimeters, and that central aperture acts as an outflow duct for the retained viscoelastic. So the chances of increased IOP have now decreased since the new version of the ICL. This is an inverted phakic IOL. Of course, if this patient comes to you, you will have shallow AC because of the inverted ICL, and this will cause an angle closure and increase the pressure. This patient warrants a removal of the ICL, and then yes, we flip it over. This is quickly a case detail of a 34-year-old male who came with both eye contact lenses, wanted refractive surgery. He had a very high power, went in for an ICL. Pentacam was fine, gonioscopy was fine pre-operatively. Everything was fine. AC depth was good. He also underwent a YAG PI. Because this was in the times of the V4B model, there was no centra flow. You can see right eye, the patient underwent IPCL. And after the surgery, you can see the pressure is now increasing. This was the pre-op, and now 42, 45, and the patient came with pain. So when we did see, yes, that the vaulting in the second day was 375, and 13th day the vaulting is increasing, and because of this the pressure is increasing. So this patient had to ultimately undergo an ICL explantation, and then he was given drops before anti-glaucoma drugs prior to ICL removal, but IOP was not controlled, therefore an ICL removal was warranted. Okay, so yes, this, you can see this study shows very clearly that with the centra flow, the chance of IOP pressure increase are much lesser than with the V4B model, which did not have a centra flow. So retained viscoelastic or intraoperative AC overfill can be a cause of increased pressure, so that we should consider. Also the type of viscoelastic we are using. If we are using a cohesive that comes out as a bolus, which might not increase the IOP as much as a dispersive viscoelastic. Pigment dispersion because of the ICL touching the iris can cause more iris dispersion and can lead to increased pressures. High vault because of increased AC crowding or incorrect measurement of the ICL size, or a long-standing PAS can cause increased pressures. So this can be confirmed on the ASOCT. Pre-existing juvenile open angle glaucoma, which of course my colleagues have discussed, should be ruled out. Malignant glaucoma, yes, this is a very dreaded condition. This will require ICL explantation and most probably also a vitrectomy. Steroid response has also been discussed, yes, to differentiate from visco overfill, whether the increase in IOP is because of the increased viscoelastic in the AC or the patient is responding to your steroids. The AGM might be required. So to conclude, yes, there can be increase in IOP both in LVC and in post ICL conditions. We have to differentiate the two. What is the cause and what should be the treatment? Glaucoma medications is the management, but yes, we do require a glaucoma surgeon on board. And other causes of IOP could still be a problem. With the newer model of the centra flow ICL, the chances of increased IOP are much less. Thank you.
Thank you, Dr. Raghav.
Thank you, ma'am.
So it was a wonderful presentation. I have a question for you. So do you do the glaucoma evaluation for all your keratorefractive as well as your phakic IOL patients?
Definitely, ma'am. Me as a refractive surgeon, all patients, even if I have the slightest suspicion, even if I have a 0.5 disc, which is pretty common in myopes, even if I have a 0.5 disc or a mild asymmetry of 0.5, 0.3 or 0.6, 0.4, I definitely send my patients at least a visual field, the baseline visual fields fields and a baseline RNFL has to be done, so that even if the patient, there is a good probability I will not see that patient when he does develop glaucoma. He might be coming up when he's 40 to some other surgeon. So these baseline tests would probably help that surgeon at that time. So doing those tests right now for my conscience is very important, because that patient, like you said, will not develop glaucoma right now, but 15 years or 20 years down the line, depending on when he gets the surgery done.
So shouldn't it be a norm to do the glaucoma evaluation for all the patients who are undergoing these surgeries, not only the baseline or the borderline patients, right?
Yes, again, ma'am, the thing is that any other surgery would not be a surgery that is warranted. A refractive surgery is something that the patient comes with.
Yeah.
So this is an added set of complications we might give to the patient, because the patient does not know that these are an added set of complications that could happen and will stay with him for his entire life.
Thank you very much, doctor.
No, sir. If we see the lens as such will be the same powers, and the biometry will not be changing. We can use the same lens in the same setting. Yes. No, sir. The ICL is very, very soft. It can just come out from the same incision. Yes. Unless we have an under or oversized ICL. So we actually should. This happened. So to center for sight, yes, but I don't know about smaller practices. But yes, they do replace it.
So actually, if we are using Star ICL, they charge for the another lens usually. But if the calculation is done by them and they suggested the lens, usually the second lens is free of cost. They follow all over. I don't.
This
know
happened about a couple of months back. I was injecting an ICL and the cartridge broke off. So there was no cartridge in our Dwarka center or the Safdarjung center. So we had to call up the Star guys, and within 2 hours they had from the Lajpat Nagar center, they sent the cartridge to us, and the same ICL was again implanted. So we'll do an ASOCT. On the ASOCT, we'll see that there is very, very low vault. We'll see the concavity, because the lens has a concavity with the convexity outwards. But if we have the convexity towards the lens, we can see it's a flipped ICL. So about 1 to 1.5 times the corneal thickness, which is about 250 to 750 is considered normal. 250 is on the lower side, but yes, I think about 400 to 750 is the perfect size. Above 850 you should be cautious, and below 300 we should be cautious. And also the change in the vault from the first day to the first month. Thank you, sir.
Thank you, Dr. Raghav. So.
Good morning, Ritesh sir. Long time. I would be talking about PISC, which is pressure-induced stromal keratitis, and IFS, which is interface fluid syndrome. Let me just say that these words sound fancy, but they are not. The basic physiology behind them is what we have been reading through and through. So, what is IFS or interface fluid syndrome? It was first described by Lyle and Jin in their case of a post-refractive surgery like LASIK, in whom there was corneal edema and vision disturbances, and they noticed there was higher pressure and also there was fluid in the interface. So there are other nomenclatures for it as well, such as pressure-induced stromal keratitis and also pressure-induced interface keratitis. The patient, it is a rare post-operative complication. Also, the information about these is not very popularly considered, because they are not easily diagnosed. It is a vision-threatening complication, and it is characterized by fluid which deposits in the interface, and it is commonly seen after LASIK and also after SMILE. It occurs due to a higher intraocular pressure, and it can happen even many years after the refractive surgery has been done. So before we go ahead about PISC and IFS, I would like to just brush up a few basics. So we know that the stroma or the corneal stroma has a swelling pressure because of the proteoglycans and glycosaminoglycans, and also there is an intraocular pressure which tends to wring the cornea and keep it dry. So whenever this disbalance occurs, the cornea gets hydrated, and that is what leads to formation of epithelial bullae. Now, the important thing to consider in IFS and PISC is that instead of collection of the water underneath the epithelium, here we have another space where the water can tend to accumulate, which is the interface in the LASIK, and which is also the lenticule interface in the SMILE. So as the intraocular pressure exceeds that of the stromal pressure, which is about 55 millimeters of mercury, we can see these changes happening. So say, as I said, when there is a raised IOP and there is an endothelial dysfunction, both of these together contribute to the formation of IFS. So in the first, we can see that there is an interface where the LASIK flap was lifted, and initially when the IOP is starting to raise, there are the endothelial pump mechanism which helps and keeps the cornea dehydrated. But let's say if this pump is overwhelmed, what happens? So when the IOP is beyond the pump mechanism, beyond the level of the management of pump mechanism, the fluid droplets start accumulating beneath this interface, and ultimately this turns into a full-fledged fluid that accumulates in the interface. Now this is what causes all the vision symptoms to the patient. So it is commonly reported after LASIK and also seen in SMILE. It can be seen in many situations, such as post-operative steroid use. Now, steroid use, definitely we give steroids to all our patients post-surgery for inflammatory response modulation. But sometimes patients also use them over the counter, thinking that they are magic drugs. We know that. Corneal endothelial dysfunction can also occur after post-operative procedures due to mismanaged handling during the process. Shallow chambers post-trabeculectomy can also lead to development of such symptoms. Uveitis is also a known pathology. Post-lamellar keratoplasty, even in the lamellar or the partial keratoplasties that we do anterior and posterior, we can see because they also have an interface formation. Scleral contact lens use is also known to cause a similar picture as IFS and PISC. So what happens basically is because of IFS, there is a cushioning due to the fluid pocket, and then there is concomitant steroid use, which leads to an unreliable IOP reading and hence very commonly missed during the OPD follow-up visits. This leads to a background progression of the optic atrophy, and ultimately the patient will lose vision due to glaucomatous optic atrophy. So this has to be kept in mind whenever a patient presents to us with normal looking IOPs and a little bit of corneal edema and haze. We have to keep this in mind because we won't be able to diagnose unless we know about these situations. There is also a staging system that has been proposed for PISC or IFS. It was devised in 2007 by Dawson. So stage 1 is a normal looking cornea post LASIK. There will be only the appearance of the stromal scar where it was. Now stage 1 is when there is a mild IFS where the stromal scar will start to appear thickened. Stage 2 is moderate IFS where there will be symptomatic thickening. Now the patient will start having visual symptoms and we will see interface haze and occasional small fluid pockets. Stage 3 is severe interface fluid syndrome where there will be diffuse confluent pockets and fluid accumulation, and it can have occasional surrounding haze. So we can see in this picture here there is a hypo intense area here. This is where the fluid is accumulating. So such pictures on ASOCT we should be wary of, and we should consider IFS and PISC. For the diagnosis part, history usually is of an uncomplicated refractive surgery, but definitely we do have to ask the use of long-term steroids in any form in the post-operative period. Symptoms could be blurring, sometimes pain, or even photophobia. Signs can be low vision, falsely low IOP readings, and corneal haze. There are multiple diagnostic tests we can obviously see on a slit lamp examination. The picture on the right can show is showing a very severe case of IFS stage 3. We have high resolution anterior segment optical coherence tomography.
Dr. Kanika, can you please conclude fast?
We also have Scheimpflug imaging program, which can through which we have densitometry program, which can tell us about the fluid accumulation. So this is a clinical picture in one of the papers that they described, and this case occurred 11 years after the refractive surgery. So there is no timeline to it. It can happen multiple years post-operative. We have to differentiate this IFS and PISC from various other clinical pictures such as diffuse lamellar keratitis, the C picture on the right, and also microbial or other non-inflammatory keratitis. The management is timely and accurate diagnosis. First of all, the eyes don't see what the mind doesn't know, so please keep this in mind for all the budding refractive surgeons as well. We have to discourage over-the-counter steroid use or any prolonged steroid use and have to make the patient aware about it. Long-term steroid patients, if require it, we have to maintain them on continuous follow-up. Most cases, only the cessation of topical steroids is sufficient, but we will also need to start some IOP lowering agents in cases which are not being able to control their pressures. And only a few may require surgical management for IOP control, such as trabeculectomies or even valves. And sometimes endothelial replacement in the form of DMEC may be required. So we should be wary, we should not forget to follow up our patient, and we should always be suspicious. Thank you.
Thank you, Dr. Kanika. Dr. Yuganki, may I have your talk, please? We'll have questions later. Yuganki, please, can we have it passed?
Yeah, sure.
Yes, please. Take 2 to 3 minutes, please. Thank you.
For the technical glitch. So glaucoma examination depends upon the corneal properties, and as the refractive surgery is growing in the past 2 decades, so the altered corneal mechanics lead to a reshaped cornea post-refractive surgery, which poses a challenge in diagnosis, follow-up, and management of glaucoma patient. These patients will require both cataract extraction and glaucoma follow-up in future. So the pre-operative assessment has already been discussed by my colleagues, is very important. Looking for the family history, first-degree relative, ocular hypertension, high myopia, tilted disc, vertical cup disc ratio, the central corneal thickness, the presence of any pseudo-exfoliation or pigment dispersion is important in assessing the patients undergoing refractive surgery. The risk of developing glaucoma, the pre-existing glaucomatous damage, the presence of the pre-operative visual fields are important in assessing in the patients undergoing refractive surgery. Patients which have high patent standard deviation have a greater chance of developing glaucoma even in the absence of visual field scotomas. It's important to run OCT, RNFL, and the glaucoma investigations available pre-operatively, because this will help in comparing it with the future measurements. The disadvantage is that the database available for these investigations include only a limited number of patients with unusual disc, and these are excluded. So digital photographing and red-free imaging of the optic disc and the comparison with future photos give valuable information about the changes of both the optic nerve and the retinal nerve fibers. The intraoperative risk factors, as has been discussed by Dr. Tulika, that there is a transient IOP rise, but it usually does not affect the optic nerve unless it is prior compromised. The effect of corneal thickness is that the myopic ablation causes larger underestimation of IOP as compared to the hypermetropic. Both PRK and LASIK can cause a reduction of post-operative IOP, and deeper the ablation, the higher the pre-operative IOP, the more is the post-operative reduction. The post-operative reduction of the IOP is due to the thinning of the corneal stroma and change in the corneal curvature, the instability of the corneal flap, and the removal of the Bowman's membrane. So the formulas which have been given to give the corrected IOP has already been discussed by Dr. Garvita. There are various devices available to measure the IOP, that is the pneumatometer, the tonopen, the Pascal dynamic contour tonometer, and a brief discussion was given in the previous presentation. The effect of the corneal viscoelastic properties.
Please conclude.
Conclusion?
Conclude.
Okay. So since we are running short of time, just to conclude that raised IOP management is a challenging task in patients who have undergone refractive surgery due to altered corneal biomechanics. Thorough preoperative evaluation of the risk factors should be ruled out and thoroughly discussed with the patient before taking up the patient. High degree of suspicion, early detection, and correct IOP measuring device is imperative in tackling the situation. Thank you.
Thank you, Dr. Yuganki. Thank you for being part of this IC, and we could have questions.